first session is the workshop 11, Surgery and Transplantation, chaired by Dr. Rinu Ganai, Dr. Nobuhisa Akamatsu, Dr. Kiyoshi Hasegawa, Dr. Takayoshi Oikawa. Doctors, please.
Good morning, ladies and gentlemen.
Good morning.
We will now start workshop 11, entitled Surgery and Transplantation. I am Kiyoshi Hasegawa from the University of Tokyo, and Dr. Akamatsu from the same department will chair this session. And also, Dr. Gyani and Oikawa are participating by web, and also will give us comments to every presentation. And also, we have 4 distinguished speakers of this session. The Dr. Arianti from Indonesia canceled to do the presentation. So the first speaker is Dr. Takaki from Okayama University Hospital. Please to start the presentation.
There are no CY for this presentation. In Japan, the inclusion criteria for OLT for HCC have been updated from meet the million criteria to meet the million criteria and or 5500 rule, which involves maximum diameter 5 centimeter, maximum number of 5, AFP below 500 nanogram per ml. Furthermore, the order placement on the DDLT waiting list depends on the MELD score, and for HCC patients, 2 points are added every 3 months. The validation of these criteria is currently underway. In Japan, OLT for cholangiocarcinoma, which is subdivided into intrahepatic CCA, perihilar CCA, and distal CCA, is not candidate for D. However, in Europe, highly selected patients with CCA are acknowledged as candidates for D, but the procedure is still recommended under study protocols. So case series of incidentally transplanted CCA is variable to define the inclusion criteria for D in Japan. So the objective of the present study was to investigate the real-world experience of OLT for HCC and incidental CCA in a hospital. We recruited 104 HCC patients who received OLT. The OS and recurrence rates were analyzed, and recurrent patients were investigated to characterize the recurrence. We encountered 5 incidental CCA patients who received OLT. The clinical characteristics of the patients are shown. Here is the background characteristics of the HCC patients. The most frequent background liver disease was HCV, followed by HBV. The maximum diameter was median 20 millimeter. The number was 2. Most of the patients are within these criteria. 15% of the patients showed no viable region, but more than half of them were moderately differentiated HCC. The OS was 73% at 10 years. The OS was divided according to these criteria within or over the criteria. Within million criteria showed relatively better OS than the patients with over the criteria. The 5500 rule did not show any such effect. OS did not differ according to historical classification. The HCC recurrence observed in 9.9% of the patients within 33 months. The recurrence rate was compared within and over the criteria. Both of the criteria showed difference, but within million criteria showed only 3.7% recurrent patients, while 5.6% of the patients were recurred in 5500 rules. Historical grade did not affect the recurrence rate. HCC recurrence associated with 70% mortality in 15 months, but 30% of them could receive curative treatment and could survive. Here is the HCC patient who could receive the DLT. 58-year-old man with rhabdomyolysis type B. He was diagnosed with HCC at MELD score 13 points. He registered for the DLT, and after 1 year and 7 months on the DL list, he could receive the DLT. At the time, MELD score was 27 points by accumulation, while the on-site MELD score was only 13 points. The tumor CT findings at registration and at the DLT are shown. In summary, OS of patients who did and did not meet the Milan or 5500 criteria did not differ to a significant extent, while Milan exhibited better prediction. The recurrence rate of patients who met the Milan criteria and satisfied 500 rule was significantly lower than that of those who did not. Recurrent HCC showed only a 30% survival rate. One patient with slow-growing HCC was able to receive the DLT. Now we move on to the patient characteristics of incidental CCA. The age was, all of the patients were male, and the age was 44 years old. The background liver disease was 2 HCV, 1 HBV, 1 PSC, and 1 no background disease. All of the viral-related patients had background HCC. The OS was 20% at 3 years. The recurrence rate was 73% at 2 years at very severe clinical course. The case series of the viral hepatitis patients are shown. All of the patients received treatment before ORT for HCC. Especially case 3 has undertaken resection 2 years prior to ORT, and the explanted histology was proved as HCC. The pathological findings were combined HCC and CCC or CCC. They had no vascular invasion, and CCA classification was ICCA. Case 1 died of infection, but case 2 and 3 experienced the recurrence of CCA. Case 2 could receive several treatments and could survive 14 months after the recurrence. But case 3 could not receive any treatment and could survive only 4 months after the recurrence. The next is the sclerosing cholangitis-related patients. Case 4 was PSC, and case 5 showed only CCA-related sclerosing cholangitis. Both of the patients had lymph node metastasis. Case 4 was ICCA, and case 5 was PCCA. Case 4 could not receive any treatment and could survive only 5 months after the recurrence. Case 5 received gemcitabine as adjuvant after ORT, which resulted in 31 months of recurrence-free survival. Additional chemotherapy with this one resulted in additional 20 months of survival. All but one case who died of infection showed recurrence of CCA. Chemotherapy administration, if possible, may improve life expectancy. So in summary, the Milan criteria is still reliable for predicting the recurrence and OS of HCC. We experienced incidental cases of CCA resulting in a very severe course. Japanese multi-center retrospective study revealed that RFS was 45% for 5 years in incidental ICCA, which in line with our present results. There are several proposed indications for ORT in CCA. One candidate is highly selected ICCA patients with a single tumor within 2 centimeters with cirrhosis, or locally advanced tumors without cirrhosis who can tolerate neoadjuvant chemotherapy. Another one is that highly selected PCCA patients with high volume center after neoadjuvant therapy, tumor below 3 centimeters, negative lymph node metastasis, absence of relevant comorbidities. The Japan criteria for CCA ORT should be explored from strictly planned study protocols to save living donors' health, as living donor ORT is dominant in Japan. In conclusion, real-world data on HCC suggested that the Milan criteria is still useful for predicting recurrence and OS after OAT. Indications for OAT in patients with CCA should be strictly defined, especially in living donor OAT predominant areas, such as Japan, to preserve the mental and physical health of living donors. Thank you very much.
Thank you for a nice presentation. Are there any questions or comments from the audience or the co-chairman from the website? Some comments?
Yeah, I like to
Dr. Gani,
ask,
please.
yeah, is there any treatment for immunotherapy in this case in CCA patients? Any chance to have immunotherapy in this case?
We did not experience the HCC recurrent patients for these with these two years, and they could not receive any immune-related treatment. They I think they received, one of the patients received lenvatinib, and one with sorafenib, and both of them could survive, but we have no ICI data.
Thank you.
Any comments?
I have one question. Based on this result, how do we use and choose Milan criteria 55500 rules in OLT? Please mention your opinion.
Excuse me, could you please ask again?
Based on the result, how do we use and choose Milan criteria or 55500 rules in OLT?
Yes, from the data, Milan is still good, I think, but recurrence rate was also not so high in the 5500 rule. So I think 5500 rule is also okay for defining the HCC ORT HCC for ORT indication. So I think 5500 rule is not bad, not bad. Okay. Still okay, I think.
Thank you.
I have one question. You mentioned that 5 cases of transplantation for CCC had incidental CCC. That means you misdiagnosed HCC as ICC as a HCC, or you did not detect the tumor itself before transplantation. Which is right?
For the viral hepatitis patients, they received several treatments of HCC, and we misdiagnosed as they recurred. They had recurred HCC.
HCC.
Yes, but after rechecked the CT findings, they are not classical HCC. The CT findings were not classical. So we must, I think we should have checked the histology if possible, but it's very difficult. So I think it's still difficult in such cases. And one patient with CCA-related sclerosing cholangitis patients, we tried several times of EOCP and blushing biopsy, but we could not find the malignant cells. So in such cases, it's also difficult. But we used adjuvant chemotherapy for him, and he could survive in total 50 months. So even incidental, so we can do such adjuvant therapy and receive relatively long survival.
Okay.
Thank you for a nice presentation. And some Japanese hepatologists may not be familiar with the criteria or for liver transplantation for HCC. So I have commented on Professor Oikawa. Actually, we use Milan criteria or 500 criteria for the indication. So we can use both criteria for the indication. And regarding this, I have one question, Professor Takaki. How about the result of the patients within Milan but outside the 500 criteria, meaning that within Milan but with a high value of AFP patients? How was the recurrence rate among these patients in your institution?
In our data, I couldn't remember such a patient with high AFP levels. The patients, some of the patients of multiple tumors with small multiple tumors showed relatively good recurrence, not so severe recurrence, and they could receive curative treatments. But I couldn't find any difference for AFP levels, so I have no idea for the AFP levels.
Thank you. Thank you for your nice presentation. Thank you. The second speaker is Dr. Ito from the Kyoto University. Please start your presentation.
Thank you for Chairman. So good morning, everyone. So today I'd like to talk about strategy of living donor liver transplantation for unresectable perihydral cholangiocarcinoma. We have no CY. This paper is a famous paper. Is from Nagoya University by Ebata professor. So the prognosis for unresectable perihydral cholangiocarcinoma is very poor. These patients may be candidate for liver transplantation. So in the United States, in the with multi-center trial with Milano Mayo Clinic, so liver transplantation was improved prognosis for unresectable perihydral cholangiocarcinoma by radiation therapy, chemotherapy before liver transplantation. So in the United States, they advocate expanding the indication to resectable perihydral cholangiocarcinoma, but this result in the resection group is a too poor result in the after resection. But the liver transplantation group is a too low survival rate. This is the not effective for raising the bottom line. So short summary. Liver transplantation for perihydral cholangiocarcinoma is preoperative chemotherapy and radiation therapy is necessary for liver transplantation on unresectable perihydral cholangiocarcinoma. In Japan, liver resection is a better option than liver transplantation for resectable perihydral cholangiocarcinoma. In the presence of background liver disease such as a PSC, liver transplant may be an option even if resectable. So this paper is liver transplantation for intrahepatic cholangiocarcinoma. The patient with single 2 centimeter ICCA after liver transplantation achieved good 5-year survival and a low recurrence rate. The patient with cirrhosis and very early ICCA may become candidate for liver transplantation. So this is a liver transplant for ICCA, so analysis of liver dissection versus liver transplantation paper. Recurrence-free survival liver transplantation is significantly better than liver resection, and the tumor size was not significantly on liver transplantation, 2 to 5 or below 2 centimeters. Liver transplantation should be considered as an alternative curative option for iCCA under 5 centimeters that have developed in the cirrhosis patients. This paper is the treatment for early stage iCCA single tumor is below 3 centimeters in the United Nations Cancer Database. Surgical resection and liver transplantation were associated with improved survival compared with the ablation or non-curative treatment. In iCCA single tumor under 3 centimeters, survival rate of liver transplantation was significantly better than surgical resection. So short summary to liver transplantation for iCCA. Liver resection and lymphadenectomy should be the treatment of choice for single iCCA. Cirrhosis patient with unresectable single iCCA below 3 centimeters may be offered liver transplantation. Patients with larger and multifocal iCCA may benefit from liver transplantation, but this is controversial, the need for the adjuvant protocol or need to adjuvant treatment. So from here, I'd like to talk about our experience with liver transplantation for CCA. So principle of liver transplantation for unresectable CCA. So patients are potential candidate for LDLT. One is the insufficient future remnant liver under 30% and ICG-KLM under 0.05. Two is extensive local advancement, impossible vascular reconstruction, hepatic artery or portal vein. Excuse me. Extensive longitudinal extension, positive margin even with trisectionectomy. 4 is coexistence of primary sclerosing cholangitis, PSC, difficult to determine the area of the cancer spread. The previous presentation is PSC is it is difficult to diagnose the cholangiocarcinoma. So LDLT program for unresectable CCA was launched in 2018. Indication criteria is unresectable cholangiocarcinoma because of one of the aforesaid 4 reasons. Exclusion criteria is distant metastasis or lymph node metastasis. Our protocol is a neoadjuvant chemotherapy and radiation therapy over 3 months. Not strictly specified, but both performed as rule. Need a staging laparotomy for lymph node sampling 2 to 3 weeks before LDLT. So this is our prospective study. So 11 cases is registered, but 2 cases excluded because of the one is we performed the liver resection, is one is monetary reasons. And 9 cases received the chemotherapy such as GCS. And the 2 cases excluded because of the one is tumor progression, and one is uncontrolled one due to the ERCP. 7 cases is scheduled LDLT, and after them they received the radiation therapy. So 7 cases received the staging laparotomy, sampling in the number 8, 12, 13, and 16. So one is excluded because of the positive lymph node metastasis. Lymph node number is 12. So 7 cases received the LDLT. Excuse me. So this patient is characteristics is a patient. So this yellow, this orange bar is received this LDLT for very high cholangiocarcinoma patients. So one is the iCCA patient. So all cases is received liver transplantation, is all cases alive, but one case is he founded the bone metastasis 10 months after liver transplantation. So I show the detail of the 5 cases. So for these males advocate a local advancement is cholangiocarcinoma. So this is tumor is here, and left dominant tumor inverted right hepatic artery and the portal vein. In the particular, artery reconstruction was extremely difficult because A6 and A7 are around separately. Lymph node metastasis was suspected. So this case is we performed the chemotherapy for 7 months. And after he received the radiation therapy, so this is the positive lymph node is disappeared. And then we staging laparotomy is check the lymph node. This lymph node is not detected tumor cell, and we performed the LTLT. So this is a pathological diagnosis. This pathological is adenocarcinoma moderate to poor differentiation. So this the residual tumor is very few and surrounding the fibrosis. So this patient is he found in the multiple metastasis after 10 months of liver transplantation. Sarcom and the cervical vertebra. This part he received the radiation therapy, and then he received the systemic chemotherapy. And after then, gene panel test result indicated that the niraparib was suitable and the treatment was initiated. After then, all bone metastasis is almost disappeared. But now he received the chemotherapy. So for discussion, conversion or salvage resection or liver transplantation, this is the controversial. So whether is this or the possibility of conversion of salvage resection instead of the transplantation, if the patients respond by neoadjuvant therapy, this is we have no answers, curative answers. So impossible vascular reconstruction and positive margin. Liver transplantation should be actively considered because of the difficulty in determining where or not reconstruction is possible, where or not zero resection is possible. Enormous impact if resection is not possible. So this is conclusion. Liver transplantation for very high cholangiocarcinoma and intrahepatic cholangiocarcinoma is feasible and can be the last version for unresectable cholangiocarcinomas. Long-term outcomes should be carefully monitored. Thank you very much.
Thank you for a nice presentation about your challenging in Kyoto University. Are there any questions or comments, please?
Good morning. I'm Dr. Cha-Young Rim from Korea University, Seoul. I'm a radiation oncologist. And I have 2 questions about your Kyoto protocol. First one, I'm curious about the literature background. How can you manage to set up the, can we call it a neoadjuvant or bridging radiation therapy? And second question is, we are very rarely treating radiation for cholangiocarcinoma in our center, but we do quite a lot for HCC. Because HCC is in our country, they are HBV related, they expanding rapidly and rigorous rapidly. But surgeons very complain about the liver became very, what they say, it's they say as a metaphor, it became like a sausage. So it's very difficult to do the surgery. So as a surgeon, how do you feel after the radiation therapy of cholangiocarcinoma?
Okay, thank you very much for the very good, very important in the question. So, please excuse me, the one question.
Number one is the literature background of the radiation therapy before LDLT in cholangiocarcinoma.
So background liver transplant, background
yeah.
liver, background liver disease.
Yeah, because that protocol is a little bit very new for me. I have never seen that kind of strategy. So,
I see.
Any articles I can do reference or?
So our this patient is almost normal liver is for cholangiocarcinoma patients. So they can tolerate the radiation therapy and chemotherapy. So in the we do the about 3 months is the patient receive that chemotherapy. After then we do the radiation therapy of about 1 month.
Sorry, I mean.
So you mean?
What kind of previous reports do you?
A previous report. So in the
did you construct the Kyoto protocol?
So and about the cholangiocarcinoma.
Yes, is it standard in NCCN or ESMO?
So SCC is we don't know, we don't use chemotherapy and radiation therapy.
And,
そうどういう根拠を持ってその京都プロトコルを決めたか。
So we the Mayo protocol is Mayo protocol is need to the radiation therapy and chemotherapy. So we modified this for the liver transplantation, living transplantation. So Mayo is cadaveric liver transplantation. So we do the modified living transplantation.
Thank you.
So and the second question is after radiation therapy, it is difficult to the operation. So these cases, 2 cases, we have the hepatic artery thrombosis. Yeah, so because radiation, so hepatic artery is slightly damaged radiation. So after then we change the hepatic artery reconstruction is modified. So we almost always we do the hepatic artery reconstruction using a normal hepatic artery, but
hepatic artery damaged because of radiation.
So we change the hepatic artery reconstruction using the gastroepiploic artery. We reconstruct use the when we do the artery reconstruction. So hepatic artery is very damaged, have the damage.
How about the tumor reduction?
So tumor reduction. What you mean?
After the radiotherapy, cholangiocarcinoma
So
regress.
very effective is the radiation therapy. So this all patient is very effective in the radiation tumor is about 20 to 30% before
100 to 20?
Yes.
Okay.
Thank you very much.
Are there any questions, comments? Okay. Dr. Gani, no question. I have one question. The preliminary results of your institution may be acceptable because the recurrence occurred only only one case. When we constructed the 55500 rule as the indication of transplantation for HCC, we considered the acceptable recurrence rate and overall survival. What do you think about the acceptable recurrence rate and the overall survival for the of the after liver transplantation for cholangiocarcinoma?
It is a very difficult question. So I think about 60 to 70 is after 5 survival rate is 60 to 70% is acceptable.
5 years?
5 years, yes.
60 or 70%.
So, but maybe because is cholangiocarcinoma after resection is more survival rate is about
40%,
but is an unresectable patient is more poor is survival rate.
But we have to consider the overall survival after transplantation, liver transplantation for other disease, because the survival time rate is now remarkably improved to 80% or
I think so.
90%.
Yeah.
What do you think about?
Yeah, but in the short time survival rate is acceptable. About the 2 or 3 years survival rate is almost is 90 over 19. So after then, we think is this disease prevent the recurrence is more important. So we consider that. Next, we consider the adjuvant chemotherapy. We need to do the neoadjuvant and adjuvant chemotherapy.
Thank you. Thank you very much for your nice.
Thank you very much.
Now the latter two presentation will be chaired by me, and the next presenter is Professor Tokodai from Tohoku University, Japan. Please start your presentation.
Thank you, Chairman. My presentation is about our strategy for liver transplantation with marginal donor for HCC cases. We have nothing to disclose. So guidelines in Japan for treating hepatocellular carcinoma suggest liver transplantation as the best option for patients with Child-Pugh C. But due to the limited number of deceased donors, liver transplantation has been performed as a living donor liver transplantation and considered an exceptional treatment option in Japan. However, the revised organ transplant law implemented in 2010 has led to a steady increase of deceased donors. This graph shows the number of liver transplants in Japan. The blue bar indicates living donor liver transplantation, and the red bar indicates deceased donor liver transplantation. Most liver transplant has been performed as a living donor liver transplantation, but in recent years, DDLT, deceased donor liver transplantation, has been gradually increasing and now accounts for around 20% of all liver transplantation. So the position of liver transplantation in treating hepatocellular carcinoma is changing dramatically due to the increased number of donors and the expansion of indication criteria. Previously, tumor condition needed to be within the Milan criteria, but now the 5-5-500 rule has been added, providing more patients with the opportunity for liver transplantation. And the other kind of treatment option is available in the waiting list, and after the registration, 2 points are added every 3 months. Thus, the total number of DDLT has been increasing, and the indication criteria have been expanded in Japan. Furthermore, we believe that using marginal grafts can bring opportunity to more patients with hepatocellular carcinoma. In Western countries, the use of marginal donors is even more advanced, and DDLT from older donors are becoming more common. Here is a report from a transplant hospital in Italy. Many DDLT from donors older than 70 or 80 years old have already been performed in the early 2000s. This graph shows the long-term results. According to the donor's age, the outcomes are almost equivalent regardless of donor age, but of course with a proper selection of other factors such as ischemia time. The age of deceased donor in Japan is mainly from 30 to 70 years old. As a comparison, I will show the data from Karolinska University Hospital, a Swedish transplant institution. As donor age, to 70 years old account for 30% of the total, followed by the 50 to 60 and the 70 to 80 at 20% each. Considering the Japan's aging population, we believe that more organ donation from older people could lead to liver transplants. Moving on to fatty liver, the classification of steatotic liver and the indication for liver transplantation. Mild steatosis is acceptable, and a moderate liver graft is controversial, and severe steatosis is basically unacceptable as liver grafts. This review shows that moderate steatotic liver, 30 to 60%, can achieve 80% or more of first-year graft survival. But of course, the steatotic liver graft has some impact on post-transplant outcomes, and our previous analysis confirms a strong association between fatty transplanted liver and ischemia reperfusion injury and acute kidney injury. As the graft steatosis became more severe, less than 10%, 10 to 20%, 20 to 30%, and greater than 30%, the rate and the severity of ischemia reperfusion injury and acute kidney injury became higher. So talking about the policy in my institution, the donor selection rule at our institution has no upper limit on donor age, and up to 60% of steatosis is within the indication. And we believe that patients with hepatocellular carcinoma in stable general condition could be good candidates for DDLT using marginal grafts. As a result of the change in our DDLT policy, the number of DDLT cases has increased, and we performed 13 DDLT cases. We performed 13 deceased donor liver transplantation almost for 1 year, and all these 13 cases, all these 13 patients have become stable condition without HCC recurrence. Marginal donor cases are shown in the table. This is a table showing the marginal donor cases in 2023, this year. I will present the third case, a 60-year-old male with no other treatment options for HCC, but a low MELD score of 13 points, which indicates a low chance of receiving DDLT. He was placed on the waiting list at position 69th. The donor had a history of alcohol addiction. The maximum SDLT level were very high, and the CT finding showed a high degree of fatty liver. Almost all the other centers declined, and we also declined this donor with the other patients. And finally, this donor finally allocated to this patient. Because he received severe steatotic liver, he had a prolonged coagulopathy after revascularization and lost a large amount of blood during the transplant operation, over 10,000 milliliters. But he was discharged home 33 days after the operation. He is now attending outpatient clinic in good health. At the present, HCC is also recurrence-free. So in conclusion, the number of deceased donors has been increasing also in Japan. The patient with HCC in stable general condition could be good candidates for marginal donors. Utilizing marginal donor will allow us to treat more patients with hepatocellular carcinoma. Thank you for your kind attention, and I want to thank Bjorn Eriksson and Greg Novak for their kindness in using the data in Karolinska University Hospital. Thank you very much.
Thank you. Now this paper is open for discussion. Is there any comment or the questions from the floor or from the web?
I like to ask questions. Thank you for the opportunity. You mentioned the steatosis as one of the requirement for the LDLT, for the DDT in this case. But how about the fibrosis? Because fibrosis may be also one of the factors affect the results of the liver transplantations.
Thank you for question. Talking about fibrotic liver graft.
Yes.
Yeah, okay. We had a fibrotic liver graft, so basically we don't accept the certain amount of fibrosis. But it's a little bit difficult to check how much the fibrosis is during the operation. So we check the liver, and if touch the liver, and if the liver is hard to touch, I mean the liver is hard and the liver fibrosis is suspicious, I think we will decline those liver grafts.
Oh yeah, do you have any specific fibrosis numbers that you have to reject the graft? I mean, is it F2 or F3 or something like that?
Okay, thank you very much. But I think it's not so easy to diagnose this liver graft is F1, F2, F3 during the operation, during the procurement procedure. So we don't have any criteria regarding the fibrosis number.
Thank you.
May I ask you? Oh, please go ahead.
I'm Sakamoto from Japan. Very interesting talk. So you mentioned about the steatosis. Then the steatosis could be caused by several factors, such as alcohol and metabolic dysfunction or others. So the case was alcohol associated. Alcohol associated may be more easy to be reversible because if the patient stops to drink, then maybe go to normal condition. But so how about the etiology of steatosis? Does it matter for the criteria or marginal?
Okay, thank you very much. I think that in our cases, 2 or 3 severe steatotic donor cases, and one is alcoholic, and 2, I think, from metabolic syndrome.
So it doesn't matter about the cause?
Yes, I think the alcoholic steatosis is can recover during the I think the brain death to procurement procedure. So when we procure the liver, almost all the steatosis has recovered. Sometimes it happens sometimes. So I think, but we don't have any definite criteria about the etiology. So metabolic syndrome or alcoholic syndrome, we don't have any criteria. But we feel that the alcoholic steatosis is somewhat can be accepted easily.
Thank you.
May I have one question? You mentioned that first of all, I congratulate for your successful results, and my question is, how do you think about with a small, for example, solitary CC with the child C patient awaiting for liver transplantation, and his liver condition is not so bad, maybe like a lab medal or around 16, but he is now accumulating exceptional point for the in such case you use very risky marginal graft, or you wait for the next chance with accumulated expressional MER point to be elevated, like 24, 26. How do you think about it?
Thank you very much. We don't have many experience in Japan, so we are wondering, always we are wondering whether we should accept this graft or not. So I don't have any definite answer. Yeah, but basically, yes, it's a very difficult question, but basically, yes, my center is located in Sendai, and so cold ischemia time is relatively longer than many institutions in Kanto or Kansai district. So yes, sometimes, but we don't have any definite answer. I'm sorry.
Thank you. In my opinion, I will wait for in such cases, but patients with a very nearly upper limit of the criteria in Japan, we will accept the marginal graft if the donor will come down to the lower patient. Thank you. Thank you for your presentation. So the last presenter is Professor Tokumitsu from Yamaguchi, Japan. Please start your presentation.
Thank you, Chairman. And it's a great honor to be given this opportunity to present today. Today, I'd like to talk about the laparoscopic left medial sectionectomy according to tumor localization. This is my COI. Laparoscopic liver resection has been gradually developed in our department, and until now, we have performed in more than 400 cases of laparoscopic liver surgery. And nowadays, laparoscopic liver surgery, liver resection is the first choice of simple hepatectomy for hepatocellular carcinoma and liver metastasis and so on, except for a giant tumor and severe adhesion. And since 2016, laparoscopic surgery has been applied to anatomical liver resection in your department. Today, I'd like to focus on the left medial sectionectomy. There are some specific features which can be suitable for laparoscopic liver resection, such as, for example, anatomical landmarks such as Hirschhorn ligament and umbilical portion, and straight dissection from the caudal to cranial side dividing G4 provide exposure of umbilical fissure vein, the root of middle hepatic vein, and demarcation line. So we'd like to talk about the standardization of laparoscopic left medial sectionectomy according to tumor localization in your department. We use two different approaches for tumor inside segment 4 and tumor across the hepatic hilum. Let me explain the approach for tumor inside segment 4. First, the laparoscopic liver transection on the left side of the tumor was performed, and this provides a demarcation line. After dividing G4, this provides a demarcation line and the exposure of umbilical fissure vein and root of middle hepatic vein. Next, liver parenchymal transection along to middle hepatic vein from caudal to from cranial to caudal side was performed. Then the cutting line on the hepatic hilum was divided, and finally, the cutting line on the right side of the tumor can be divided. And we consider that this fissure hilum or fissure approach can be a standard approach in our department. This is a video of standard approach. The first umbilical portion was exposed. Liver parenchymal transection on the left side of the tumor was performed, and branch of G4 was clipped and divided. And this provides exposure of umbilical fissure vein, this one, and root of middle hepatic vein, and demarcation line. After that, liver parenchymal transection along the middle hepatic vein can be performed. Then cutting line on the hepatic hilum was divided, and further transection of the ventral side of the middle hepatic vein was performed. After that, liver transection on the right side of the liver tumor can be performed. And finally, the specimen was removed. However, there is a difficult case to apply the standard approach because of tumor close to the hepatic hilum. In such a case, even after transection on the left side of the liver tumor, there is limited space between the hepatic hilum and liver tumor. So there is a potential risk of injury of short branch of the coded lobe. In such a case, liver transection on the right side of the tumor, followed by the dissection on the hepatic hilum, can be performed. And this fissure and hilum approach, that is, hilum last approach, can be useful for tumor close to the hepatic hilum because this approach provides a clear view of the hepatic hilum. This is a case of the hepatocellular carcinoma close to the hepatic hilum. Umbilical portion was exposed. And liver transection on the left side of the tumor can be performed, and the middle hepatic vein was exposed. Even after that, there is a limited space between the tumor and the hepatic hilum. In such a case, liver transection on the right side of the liver tumor can be performed before transection on the hepatic hilum. In this case, G5 was clipped and divided, and middle hepatic vein were also clipped and divided because this case requires extended sectionectomy. After total parenchymal transection, the specimen can be pulled down, and this provides a clear view of the hepatic hilum. And short branch was ligated and divided, and specimen can be removed. And in this case, we inserted the biliary drenal tube by a common bile duct to prevent postoperative bile leakage. This is a result of laparoscopic left medial sectionectomy. We have performed a total of 10 cases, including 2 hepatic hilum last approach. Although the operation time is long, but there is no open conversion, no postoperative bile leakage, and no mortality. In conclusion, laparoscopic left medial sectionectomy can be achieved safely by standardization according to tumor localization. Thank you for your kind attention.
Thank you for presentation. So now open for discussion. Is there any comment or the questions from the floor or on the web? May I ask you one question? How many cases with the complete resection of the left medial sector in your series? Complete resection in the segment 4. The video shows that the superior side of the segment 4 and the inferior side of the segment 4 sectionectomy, maybe. Did you take the, how was the complete resection of the, how many cases do you have the experience?
Complete resection in laparoscopic surgery.
Yes, of course.
Thank you. Thank you for your question. We performed 10 cases, and one of them we used hand-assisted surgery, but the other 9 cases we performed totally laparoscopic surgery. And
sorry, my question: the complete resection of segment 4, not
the
superior segment 4 superior side, or not for inferior side, not complete resection of segment 4. Okay, do you have with a laparoscopic surgery?
Complete resection, yes, sectionectomy, left middle sectionectomy, complete resection is at all 10 cases totally.
Oh, really? The former videos, in my sense, our former video preserved the inferior segment for not exposing the hepatic hilum. Did you expose the hepatic hilum in the former video you were presented in this presentation? The relatively large amount of parenchyma was preserved on the hilum. Maybe not complete resection of the segment 4.
Sorry, just
Is there no additional comment or question? Okay, thank you. Thank you for your presentation.
Thank you very much.
Now it's time to close the session. Thank you for joining our relatively minor session and with fruitful discussion. Thank you very much.
Thank you.
Thank you, Dr. Nani. Thank you.
Thank you very much.
Thank you very much, chairs and lecturers.